Hi, my name is Christina Jadushitsky. I am the founder of New Life Physiotherapy, and I'd like to welcome everyone to this educational seminar on the physiotherapy approach to prehabilitating and rehabilitating prostate cancer surgery patients. It's always a pleasure and honor to talk about pelvic floor physiotherapy, raising awareness about this highly effective treatment option for the management of some of the side effects that can occur after having your prostate removed. Always holds a special place in my heart, and I'm always excited when I get to share this knowledge with those who are afflicted. So tonight's webinar will run approximately 40 minutes. We'll have a couple of breaks, and then at the end, we're going to learn a highly researched pelvic floor physiotherapy protocol so that everyone can start improving their current condition. All right, without further ado, let me introduce myself. I am a registered physiotherapist, and I work with men, women, and children who suffer from urinary incontinence, pelvic organ prolapse, constipation, pelvic pain, and many, many conditions. But I decided about 8 years ago to start specializing in men's health, and it was a twofold reason. First of all, because I had found out that men's health lags behind that of women's health by approximately 30 years. And then secondly, I was basically taken, or I was given an opportunity from some of the leading urologists across the greater Hamilton area to come and spend days with them in clinic and watch what they do. And then also I had an even more exciting opportunity where I was able to go in the OR and observe the surgeries that are being done for prostate cancer patients. This opportunity had just enlightened me in more ways than I can even explain. I was able to marry the knowledge that I had acquired from my physio training and all the ongoing education courses that I had taken thereafter to specialize in pelvic floor physiotherapy, alongside my 21 years of passionate commitment to exercise and fitness. And all that knowledge that I had acquired over this time allowed me to come up with very unique training protocols that have been proving to have great success for my male patients who are suffering from some of the consequences or side effects that one can experience after having their prostates removed. So let us begin with the presentation. And I always like to start off with some interesting facts. So did you know that 3.5 million Canadians suffer from urinary incontinence? And 1 in 9 of these men will experience urinary leakage. Prostate surgery is the most common cause for this leakage, and then regaining control may take up to 1 year. Furthermore, we've got 60 to 70% of men will have long-term erectile dysfunction following prostatectomy, and the recovery here can take anywhere up to 4 years. But don't fret, there's good news. Pelvic floor physiotherapy can help reduce the time frames to recovery. In fact, they can reduce these time frames almost about half of that, especially for the incontinence. We can manage that within 6 to 9 months instead of a year. So there's certainly hope, and I'm excited to share the exercise protocol that will help you with this. All right, so what we're going to be covering today is essentially what one should expect after having your prostate removed. Why do these side effects occur? And then how does pelvic floor physiotherapy help with the outcomes? And then, like I said at the outset, we're going to be learning an evidence-based exercise protocol for training the pelvic floor muscles. Okay. So urinary leakage and erectile dysfunction, these are truly the nuts and bolts of this presentation. So we're going to go into these two in quite a bit more detail. But there are also a few others that are perhaps not as discussed, and I find that it's important because a lot of men think that something might be going wrong after they've had the surgery, and they constantly tell me, I wish somebody would have told me. So I'm going to tell you, and then we'll come back and we'll talk in much more detail about urinary leakage and erectile dysfunction. So the loss of penile length. A lot of men kind of come out of surgery and they're a little bit shocked to find out that the penis doesn't have quite the length, or the shaft of the penis isn't quite as long as it was prior to surgery. And the reason for that is because let me get my pointer out here. And if you guys can just follow along here, we've got the bladder, and then we've got the prostate that sits right below it. And then the bladder neck here, the extension is the urethra, and it travels right through and out the shaft of the penis and out the glands. So what happens when we have a prostatectomy is that this prostate gland here that measures approximately 2 to 3 centimeters is removed. And so they have to reattach the bottom portion to the bladder neck. And in doing so, you're going to lose about 2 to 3 centimeters. And if you have a larger prostate, it could be slightly more. But that's typically what happens right at the outset. Then there's its ongoing loss of length that can occur because of a process called fibrosis. And this is because men lose up to about 1,500 nocturnal erections. So those are those nighttime erections that men get and often wake up with that morning glory. And we're going to talk in quite a bit more detail about those so that you can understand why penile rehabilitation is extremely important after your prostate has been removed. Then there's another condition here that can appear for those who've had a prostatectomy about 14 months after the surgery, and it's called Peyronie's disease. And so Peyronie's disease is the curvature in the penis, and if you see here in this picture, we have the penis that's starting to curve upward, and that's because of these plaques. So you can see these fibrous plaques that are developing here. And usually that's as a result of having low blood flow in the penis, and that causes structural changes, which is also something we're going to get into in quite a bit more detail so that you can understand and appreciate the importance of penile rehabilitation immediately after the catheter is removed. And I'm really emphasizing penile rehabilitation because I think it's kind of left a little bit too late in treatment. Most of the time we want to manage the incontinence first and then we deal with the erectile dysfunction, but you'll come to see that that's not always the best option. So these particular curvatures can become quite painful, and they can become quite severe that they're no longer able to penetrate. So naturally you can imagine that can disrupt one's quality of life. There are some treatment options for this. Ultrasound seems to be somewhat effective, but again, not high levels of evidence yet. Shockwave or low intensity shockwave therapy, also there's some evidence, but again, very new in its discovery, so it's not overly certain how effective it is. And then there's a surgical procedure that can be done, but then again with that there's always risks because now you're potentially putting in more scar tissue as a result of opening and dissecting the penis to remove the plaque. For men who've had radiation, it's going to be about 1 in 8 men, and that'll appear within 3 years. And the reason why it's so much later is because the cells that have been radiated over time, they start to degrade, and it continues to get worse and worse as time goes by. They also lose their ability to stretch. They're not like they once were, and because they become very, very tight, you can imagine that all that tissue will start to kind of retract towards itself. Now, dry ejaculation is also something else that many men seem to be shocked about and are very concerned at the first experience, because first of all, they probably didn't realize that they could have an orgasm without being erect. And then when they have the orgasm and nothing comes out, they're concerned because they think, oh, is something blocking the area? Has the cancer come back? And they're very worried about this. And so they always ask me, or they always mention to me that they wish that somebody had told them about this, so that they're not concerned when it does happen. And the best picture, now this is not an exact representation, but the best picture that I could find here is this one here, where you can see that basically the plumbing gets cut. And although it doesn't happen right at this spot, it actually happens right behind the bladder neck here in this area, where they're going to remove the seminal vesicle, they'll remove the prostate gland. And then that's why when the sperm that starts in the testicle makes its way up the vas deferens, there's no longer anywhere for it to go. So there's not going to be any ejaculate that comes out. And that's going to naturally cause a situation where the man might experience something different than he otherwise had, which could take some time to get used to. And for the partner, it just might mean that there's not as much of a mess to clean up afterwards. So Climacturia is another condition that men tend to be a little bit shocked about when it happens. And this occurs when men become aroused or have an orgasm and they have this involuntary loss of urine that starts to present itself. And this can occur in approximately 30% of men. Some of the risk factors are the time since surgery, because the muscles, of course, are compromised and not quite as strong, and certainly not ready to address what's occurred or what's happening. And then if you've had a prior prostate kind of coring out of the inside, it's called a TURP. If you had that kind of procedure done, that could also put you at risk. If you have a shorter urethral or penile length after the radical prostatectomy, that can also put you at risk for having climacturia. Naturally, an effective treatment option for this is pelvic floor muscle exercises, and that was proven in 2015. And then other treatment options beyond the exercises is that you'll want to empty the bladder prior to sex. You'll want to wear condoms to catch the urine and use a penile variable tension loop, which is what you can see here in this image. Here is the penis, and the urethra is located right in this area where you see this red cursor coming down. And what you see here at the bottom is the variable tension loop that wraps around the base of the penis, and you pull it tight enough just to squish the urethra closed. That's all. So it's not to create compression on the penis outside of where the urethra is located. It's just literally designed just to compress down and then prevent any urine from coming out. All right, so let's go back to incontinence, and then we'll touch on erectile dysfunction. So who's at risk for incontinence after having their prostate removed? Well, older patients, of course, because if you haven't used the muscles that are necessary to keep you continent, then you're going to obviously be at more risk. And as we get older, these muscles tend to shrink in size. And if you don't use them, you lose them. A larger prostate size is another risk factor, and that's because if you look at this image here, there's your bladder, and then here's the bladder neck, and then inside the prostate you'll have an internal sphincter, and you'll have this healthy prostate on the outside. So when the bladder is full, it'll squeeze, and the internal sphincter inside the prostate will open up, and it will allow the bladder to empty its contents. However, if we look on this picture here and we see a bladder here again, but now we see a prostate that has enlarged. And as you can see, what happens is that the urethra starts to get pinched. So when the bladder is trying to empty its contents, when it starts to squeeze down, as you can imagine, the pressure in here is quite high. So the bladder has to squeeze way harder to try and get the urine out. And over time, the longer it has to develop this habit, it almost gets into what we call a wrestling bladder syndrome, or something similar to an overactive bladder. And when you remove the prostate, the bladder doesn't necessarily get the memo. And so it's kind of developed this habit, and it's going to continue this habit. But fortunately, through bladder retraining protocols, we can start to help settle that bladder down and start teaching it that it doesn't need to work against as much pressure, and it can quiet down. Now, if you have an elevated BMI, which just basically means how much body weight you carry, you'll notice that in the beginning, that's going to hinder your ability to be continent, because you're putting a lot of extra weight on the abdomen, which then puts weight on the bladder, and then ultimately puts more pressure on the pelvic floor muscles that you are now 100% reliant on. And we're going to talk about that in a little bit. So having too much weight, especially in the beginning, has shown to be a risk factor, but as time goes on, it starts to become less and less of a risk factor. And then, unfortunately, genetically, if you have a shorter urethral length, which is essentially, if you look at this picture here, we've got the urethra that travels in through this area here. But depending on how much is left in this area here, will make a difference in terms of how continent you are. Because if you can imagine, if you've got a muscle, because what we see here is a muscle that's surrounding the urethra, and a bigger muscle will do a better job at closing down the urethra than if you just had, you know, a tiny little muscle that was closing down on a shorter urethra. Okay, so bulkier, bigger muscle will be more effective at keeping you continent. And so that's why that urethral length makes a difference. Okay, and it's one of the big reasons why incontinence will happen. So what causes incontinence? We've kind of been touching on it a little bit, but let's really get a good picture of why this is happening. So what's happening is that you're removing the internal sphincter. And if we look at this picture over here, we've got the prostate here with an internal sphincter inside of that. We saw that in the previous picture. And then we've got the external sphincter just outside of the prostate. Now, it's important to understand the difference between an internal sphincter and the external sphincter. The internal sphincter is a smooth muscle. There are various muscles in the body that are smooth muscles, and when we call them smooth muscles, it's because we don't have control over them. So, for example, the colon. We can't tell the colon, okay, colon, start, moving my food along and digesting my food, or we can't tell the heart to start beating. We can't tell the bladder when to contract, right? Those are all things that happen under our involuntary control. The brain is in 100% control of that. So a smooth muscle, we don't have control over. But the external sphincter, which is considered a striated muscle, those muscles we do have control over. So if we think about straightening out our arm, and then we say, okay, bend the arm. Well, we have control over the bicep muscle to bend the arm, right? Or raise the arm, or whatever action you're trying to do. Those are striated muscles. And fortunately, after your prostate's been removed, that striated muscle is still there, which means you can actively contract that valve and squeeze it shut so that you're not leaking. And that is the whole premise of doing pelvic floor muscle exercises, is that we want to strengthen what's left, because the primary worker that we didn't have to think about is being removed. And now you're left with this kind of helper muscle that was never conditioned to take on 100% of the job. And so that's why it's so important, hopefully before you ever go into surgery, 6 weeks before, but certainly afterwards, to build up the strength of these muscles so that you can maintain continence and you can go back to living a normal life, not having to wear diapers and not having to worry about the embarrassment. Damage to the external sphincter, however, can happen, because what happens here, if you come into this picture here, you can see the external sphincter muscle here at the base, and then you can see the bladder neck at the top. What they're doing here is they're suturing or connecting with little thread-like things they're connecting the base of the bladder to the muscle here at the base, and they're just sewing it together essentially. And there's only 6 sutures here that hold these 2 pieces together. And I'm going to mention it now, and I'll say it again at the end because it's very important. Remember, it's only 6 little sutures that are holding your bladder neck to the muscle just below it. And when they say don't lift more than 10 pounds after surgery, I highly recommend you follow those orders, because if something was to go wrong here, that could be a very, very bad situation, okay? And you want to give it enough time to heal and connect itself and find itself so that you're not having any issues there. But while it's healing, that external sphincter could be under trauma just from the nature of sewing the 2 together. And sometimes if the cancer has spread out a little bit further than expected, they may have to remove a little bit of that too, right? And then, as I said, now there's an increased demand on these striated muscles. So 100% of the work is dependent on these striated muscles because that internal sphincter has been removed. And so it's really important to strengthen and bulk up these muscles through pelvic floor physiotherapy. All right, so there's a few types of stress incontinence. We alluded to one earlier when we were talking about that larger prostate and then causing that kind of wrestling bladder syndrome or that overactive bladder syndrome. So that's the urge incontinence that you see here as number 2. And what happens is that it's kind of like this inability to suppress a sudden strong urge to urinate long enough to make it to the toilet in time. And so you can lose full control. It can happen at any time. It's unpredictable. You can be sitting, lying, standing. It's highly unpredictable. So there are medications that can be prescribed to kind of help manage this. There's definitely bladder retraining protocols that we give as pelvic floor physiotherapists. And then there's also the pelvic floor muscle exercises. Sometimes in these scenarios, we actually have to do something called a reverse Kegel or down training of the pelvic floor muscle because of the habit of, holding tight for so long. And so we have to actually teach patients how to let go of these muscles, and that can happen sometimes. But the main one that we see is the stress incontinence. And that's the one that happens when there's increased pressure on the abdomen and we leak some urine. When you cough, when you laugh too hard perhaps, when you're getting out of a car, maybe even golfing, all those kind of things. If you're lifting a heavy object, those kind of things would increase pressure, especially if you're holding your breath while you're doing all of that. And men have a tendency to hold their breath before they lift. It's actually called the Valsalva maneuver, right? They will take a deep breath in, they hold, and then they lift. But what you're actually supposed to do is take a deep breath in, exhale, contract the pelvic floor muscles, hold those muscles, and then perform your activity or perform your cough. And try to remember this, because before we do the active portion of the webinar, I'm going to ask you guys how many people forgot to do this. Just keep this in the back of your mind. And then the last one, we don't see it as often, but it is overflow incontinence, and it's basically an obstruction due to scar tissue formation at the bladder neck. So when they put that catheter in, as they're connecting, if I just go back to this slide here, so when they're putting this catheter in, which is this yellow structure that you see going into the bladder from the base, at first they put that in to make sure that it heals open, but when they remove that bladder neck, sometimes the scar tissue in the area can start getting funny and it start getting into the tube that allows us to urinate that urethra, and then that's when we can run into this overflow incontinence. So beyond pelvic floor muscle exercises, we also have to be mindful of removing bladder irritants and developing new habits. So anything like caffeine, alcohol, cigarettes, spicy foods, and particularly cow's milk, those are all real big bladder irritants. And if you are a big consumer of those products, then I would highly recommend that you try to remove them as best as you can. If you drink a lot of caffeine, maybe switch to decaf. If you drink a lot of alcohol, you've got to keep in mind alcohol relaxes the striated muscles. Remember, the striated muscles are the only ones you have left. And if you're drinking, then those muscles are going to go to sleep, and then likelihood of losing control is obviously much more likely. So I would recommend, if that's the plan, I probably suggest bring a pad just to save yourself from possible embarrassment. And then developing new habits. A lot of people tend to stop drinking water, but the issue there is that if you stop drinking water, then the water that is coming into the bladder is very concentrated, which makes it highly toxic. And the bladder doesn't like having toxic substances inside of it, so it's going to start contracting a lot to get rid of whatever is in there if it's not diluted with water. So you'll actually you'll end up into that overactive bladder situation, because it's going to constantly contract, trying to get rid of what's inside. And so you'll want to be careful with regards to the stopping of water intake. And I know it seems kind of logical, if you don't want to leak, then stop drinking, but you're actually making it worse. And you also want to avoid emptying the bladder too often, right? You want to utilize that urge. If you feel an urge to pee, you want to utilize that as an opportunity to work your pelvic floor muscles and contract them and try and suppress that urge, because now you've got to imagine that a full bladder is going to act or impose weight on that pelvic floor. And if that's happening, then that's a great opportunity for you to beef up and bulk up these muscles, which is ultimately the goal, right? The bigger and stronger these pelvic floor muscles are, then the less likely that you'll have leakage. So use that as an opportunity. Walking 30 minutes a day while holding a gentle pelvic floor muscle contraction is also a really great way to build up the endurance in these muscles. Now notice it's 20 to 30%, right? So this is not 100% contraction that you're holding the whole time you're walking. That would be impossible. Nobody can sprint forever, right? So you can hold a 100% contraction for, maybe 3 seconds, 6 seconds if you're really good. But ultimately it's really only effective up to 3 seconds. So when you're walking, you just want to hold a level that you can maintain for an entire 30 minutes. And then if you are leaking a great deal while walking, you can use what we see here in this picture, the penile clamp. This one, contrary to the tension loop that we had for climacturia, where it was placed at the base of the penis to close down the urethra, this one is actually placed at the tip of the penis. And you just, again, gently close down the urethra. You don't want to crush it, okay? You just want to squish that open, flimsy tube. The urethra, if you squish the tip of your penis, it's very, very easy to close down that the hollow tube that's allowing you to pee out of, okay? So you just want to be mindful not to restrict any blood flow. All right. And it's there's kind of very general timelines for improvement of incontinence, typically we see the hardest time to stop leakage is between the hours of 11 and 6 p.m. So that's because you've been sleeping for the entire night, and the pelvic floor muscles are postural muscles, so they're on when you're sitting, standing, and walking about. But when you're lying down, those muscles are resting. And so if you've been sleeping the whole night and then you get up first thing in the morning, you actually might find that you're the strongest first thing in the morning. And let's say you had a plan to go out for dinner, or you had an event, maybe not now during the COVID, but later on, let's say that ever gets back to being normal, and you do have an event, you might want to consider implementing an hour a day of pelvic floor muscle rest time. And that means you're just going to perform some gentle stretches on the wall while lying on your back. And so I'm just going to demonstrate this right now, if you don't. Okay, so I just want to make sure that everyone can see here. So you just lie on the ground and you get yourself nice and close to a wall. You just put your feet up on the wall. And here now, because you're in a lying position, the pelvic floor muscles are completely resting, and then you're going to give them an opportunity to perform for you for the later half of the day. And while you're here, you might as well do some stretches, because if there are tight areas in the body, it could compromise the way the pelvis is sitting. And if the pelvis isn't in its optimal position, then that could actually put you at risk of having more leakage. And so making sure that you're flexible and symmetrical too. So you want to make sure that all your muscles are flexible, not just some of them. And there is a really great video on my website. If you visit www.newlife.ca and you just click the exercise tab, you can go onto those videos, and it's called stretches, instructional videos. And these particular ones are pelvic floor muscle stretches. And you can see that I go through a series of exercises or stretches that you can perform to help open up the pelvic floor and also relax those muscles. So if you're lying down for an hour, you might as well be doing some stretches to improve your health. All right. So then we typically also see that nighttime urination is the first thing to improve. And that's, again, because I've mentioned there's no gravity acting on the bladder. Sitting improves next, and then standing is usually the last one to improve. And you can see that there's such a range because it all depends on the various risk factors that we spoke of before, and then also whether or not you're doing some pelvic floor muscle exercises appropriately. Okay. One quick word about protective padding. Okay, this here is the Shield, which is what I highly recommend men start using. I know a lot of men wear the diapers, the Depends, but in those you can't really sense if you're having leaks, and if you can't sense you're having leaks, you're not going to be mindful of thinking about engaging those pelvic floor muscles to stop leakage. So if you're not leaking, get out of your pads, get out of your pull-ups. If you're not leaking at night, don't wear any at night. If you're not leaking in the morning, don't wear any in the morning. Really start to become mindful of whether or not you are leaking. And the easiest way to do that is obviously not to be in protective padding. Okay, so be mindful of that. Okay, so here's where I'm going to let everyone take a break. If you want to pause the video, now's a great time to do that. And then we're going to get back together here and talk about erectile function and what we can do to manage that. All right. So hopefully you've had enough time to get some water or go to the bathroom if you need to empty your bladders. And so we're going to now move on and talk about erectile function. So to have an erection, it's actually a really complex process of various systems in the body working together to create an erection. But one of the most important systems, the neurological system, is extremely important, and that's unfortunately the one that gets compromised with prostate surgery. But because the neurological system gets compromised, then the vascular system also gets compromised, because the nerves are basically what tell the veins and arteries what to do, whether they should dilate or whether they should constrict. And so here is an image of a flaccid penis that is not engorged with blood. And in these chambers here, the penis is made up of 3 chambers. Okay, and these are actually muscles, and they're extensions of muscles that are coming from here. So if you can see, this is the base of the pelvis. I'm just going to show you. So there's a pelvis, okay, and the muscles are the ones that are right at the bottom, okay, and that's what you see here in the picture. So you can see that this muscle on this side becomes an extension of the penis here. This muscle on this side becomes an extension of the penis on the other side. And then you've got this center muscle here, the bulbar spongiosus muscle, that comes in and becomes the corpus spongiosum. And that muscle is the one that houses the urethra. The other 2 are the one that really get engorged and full of blood. Okay? As they get engorged, as the erection starts to occur, what we start to see is naturally blood starts to fill into these chambers. But the more important thing that starts to happen is that this dorsal vein of the penis, located right above it at the top, it starts to get compressed. And that has to happen, because if that didn't happen, then blood would be able to flow back out and we'd never be able to maintain an erection. Okay? And that tends to happen with men who start, especially who've had prostate surgery, but certainly men who have potentially cardiovascular issues. If you have a waning erection before any kind of surgical procedure, or just in general, you have, you notice that your erections aren't quite as strong or don't last quite as long, it could actually be an early warning sign for a cardiovascular event. In fact, you've got about 3 to 5 years before a cardiovascular event happens if you are noticing that your erections are starting to change. So I would suggest that if that is happening in the absence of having had prostate surgery, go and talk to your cardiologist and have your heart checked to rule out any sinister conditions that could be going on. All right, so that's typically the normal erectile function, and as I've discussed, we can lose the ability to have an erection because the nerves have been tampered with. And as a result of this, then the penis stays flaccid for, as we mentioned, it could be up to 4 years, but typically the nerve damage takes about 2 years to start improving, but it could stay flaccid for that period of time. And a flaccid penis has a very low pressure that's running through it. And in this case, it's 35 millimeters of pressure. And that creates a stimulus for collagen to get produced in the penis. And when that happens, collagen is kind of like equal to scar tissue. And so there's these structural changes that start to occur in the penis. And unfortunately in the penis, they're non-reversible. So we want to make sure that the penis is having regular erections through the time frame where the nerves are regenerating, because nerve regeneration takes a really long time. It's painfully slow. And so we have to make sure that we're doing the proper penile rehab as soon as that catheter gets out to maintain blood flow into the penis. And there's various ways to go over that or to make this happen. We'll talk about that in just a moment, but that's so that there is not going to be any scar tissue formation in the penis if we continue to have the regular erections. So here's a picture of all those nerves that get tampered with. So the prostate here, okay, that neuropraxic effect that I was discussing with you, it causes the vascular system to basically shut down, okay? So without the nerves, those vessels can't get filled, they can't do anything, and that's why you can lose up to 1,500 nocturnal erections per year. And when the prostate comes out, all of these nerves get cut. Okay, they get cauterized, and then the prostate, there's also this traction or pulling on the nerves because the prostate will get carried out up here and then out the belly button as it comes out. And so any damage to the nerves in this area could result in pain in the perineum, could result in pain in the testicle, in the anus. It could compromise potentially your bowel function. So if you're constipated, that's something you want to talk to your pelvic floor physiotherapist about, and even your doctor perhaps. If you might have burning in the penis, sometimes men will notice at the tip of the penis there's a sensitivity that wasn't there before. You might have just general sensation changes. It might not be as sensitive as it was, and that just takes some time for the nerves to regenerate. Again, I'm going to say it, early penile rehabilitation is extremely important. So what is it then, right? All right, so let's talk about it. So there's really three lines of treatment that are available right now. The first is these PDE5 inhibitors, better known as Viagra, Cialis, Levitra. And these here, unfortunately, I feel that it's not always well explained to patients that Viagra is a medication that you can't eat and take it at the same time. It doesn't work on a full stomach. So that's something, you know, men get frustrated with, and they cost a lot of money, right? Sometimes the Cialis, I've heard it going upwards of $300 to $350 a month. And if you have to do that for 2 years, it gets quite costly. So that's why sometimes this option here is not, men don't tend to adhere to it for very long, and then they also don't adhere to it because it doesn't always work, right? It does require arousal, so you can't just take this pill and expect that you're going to have an orgasm or an erection. It's not going to happen like that. You actually need the stimulus of touch, or that visual stimulus, or maybe a fantasy or a certain smell. There's various ways to achieve an orgasm, or sorry, an erection. And a second line treatment is the vacuum erection device, which we're going to talk in quite a bit more detail about, because this is probably my favorite tool to use for penile rehab, along with pelvic floor muscle strengthening. I kind of combine everything in one. So I'm looking at managing the incontinence and the erectile function, as well as the loss of penile length, all in one. So that's the treatment that I've kind of designed in obviously understanding the literature and the research that's out there. I've put all that together, and I found a very effective way to get it all done. And then there's the intracavernosal injections. And these here, if you can see the picture just below here, this is basically an insulin needle that gets injected on the side of the penis at about the 2 o'clock position. And you have to make sure you pull on the penis so that you can kind of see the veins, and you want to miss the veins naturally. And then you just inject the solution into the penis. And this will give you almost an immediate erection that will last anywhere from an hour to an hour and a half. Now, if you put too much, dosing is a really, really important thing here, because if you dose too high, you can get something called a priapism, which is an erection that lasts greater than 4 hours. And guys, it's really painful. Every man that has had it happen to them, they are, you know, unfortunately afterwards very scared to do it again, because it is a medical emergency, right? And fortunately the doctors can help bring it down, but it can be actually quite scary and dangerous. So be mindful of not overdosing on this particular medication. If anything, err on the side of caution and underdose. Okay, this should also be done, by the way, twice a week. Okay, it's not something that you want to do every day, but certainly twice a week, and that really just helps getting that blood flow into the penis to prevent any kind of structural changes over time. And then the third line treatment options are these penile prosthetic implants. So obviously it's a surgery, and so this can, you know, cause several side effects such as infection and so on and so forth. Anytime you're, you know, putting any artificial implants into the body, there's always a risk of the body rejecting them. But if it is effective, then patients tend to be extremely satisfied, and the satisfaction rate is upwards of 90%. So that's really fantastic. But it should be your last kind of option. And we can't forget about the importance of pelvic floor muscle exercises. Okay, so it's really a non-invasive addition to penile rehab. And as I mentioned to you, I use the vacuum erection device as not only a way to maintain the erection, to preserve penile length, to stop incontinence, right? And also for pleasure, because it does create an erection. And in this picture here, you can see that the the constriction ring, so I have a different type here. This is called the Vac Erect, and I have no affiliations with them whatsoever, but I just think that this pump is fantastic. So you've got the ring that you place, as you see in the picture, on the base of the penis, and then and then you pull the penis through the ring. Once the ring is placed on, you put the pump on top of the ring. You make sure it's sealed properly, and then you just start moving the pump back and forth, just like this. And very slowly, you don't do it quickly, you take your time with it. If you start to feel discomfort, then you stop. That's it, okay? But what you're gonna notice is the penis is gonna start getting full of blood, and it's gonna start to fill the chamber. Once you're in here, you're supposed to hold this out. You're supposed to hold it there for 3 minutes. And while you're in there, instead of just staying there for 3 minutes, you might as well start doing your pelvic floor muscle exercises. You might as well start contracting and relaxing those muscles, doing the protocol that's prescribed to you while you're in here. You can also use this tool as a weight training tool. And this is the special piece that I have discovered that works quite well when trying to rehabilitate and strengthen these muscles. You can use this as a way to build the size of those muscles. And that's something that I teach my patients when they come and see me in clinic. The Manta, which is the other picture here that you see on the side, is a vibration tool that men rave about because it really helps stimulate the nerve pathways so that they can, start to get better and improve over time. And so you can add that when you come out of the erect state after 3 minutes of doing your pelvic floor exercises. You'll notice that the penis stays erect for a period of time. You can put the Manta vibrator on top of the penis and potentially even have an orgasm or just enjoy the pleasure of that sensation. And this is just the pelvic floor muscle training and erectile dysfunction in radical prostatectomy, a randomized controlled trial investigating a non-invasive addition to penile rehab. This is Joanne Emilios who came out with this protocol for erectile dysfunction. Okay, so there's mechanics and ways in which we can stop incontinence from happening, and we can't use the same approaches that we used for women. Okay, because we're about to get into the exercise protocol, and it's important that we first understand how to recruit these muscles. If you're recruiting these muscles like a woman would, or a woman has been taught back in 1940, Dr. Arnold Kegel, and that's probably why many people understand or have heard of the name Kegel. If we do the Kegel, then what we're actually doing is we're potentially creating more incontinence. So the anatomy in a man's pelvic floor is slightly different, and certainly more different after they've had their prostate removed. And so what we can see here from Paul Stratford's work is an ultrasound where we can see the bladder at the top here. And so this is more just an animation of that picture here, just so you can kind of try and correlate the two images. I know reading an ultrasound is quite challenging, but we've got the bladder at the top, so the bladder would be here. Then we've got the urethra, so then the urethra is coming out here. Okay, this is your normal controlled patient. Then you've got the prostate. Okay, so we can see the prostate right in this area here. Okay, and then we've got the sphincter muscles right down here. So when the prostate gets removed, well, the bladder drops and the length of the urethra changes, right? It shortens considerably. So now what happens is that if we use this puborectalis muscle, which is the muscle that stops us from passing wind, if we use that muscle instead of these two front muscles, the striated urethral sphincter, which is that external sphincter we talked about that we have remaining, and then the one that basically compresses the urethra from beneath, the bulbocavernosus, if we don't use the two front muscles and instead use the back muscle, what we're actually going to do is compress on the bladder. If you can imagine, take this bladder, remove this blue prostate here, push the bladder down. Now what's happening is that this muscle is squeezing on the bladder. So every time you use these back muscles, you're actually emptying your bladder and causing more leakage. So it's really important to understand the technique of how to prevent leakage in men and understand that it's different than that in women. So here it is, the 12-week high-intensity exercise protocol, okay? And again, we want to try and start this 6 weeks before surgery if possible so that you have less chances of having any incontinence at all following surgery. There's two types of muscle fibers in the pelvic floor. There's endurance muscles and then there's power muscles. And so we've got to make sure that we're training both. The endurance muscles require that you hold for a long period of time. And the fast twitch muscles require you to contract quickly for about a second, maybe 3 at most, and then relax. And we need to be able to manage both because there are various activities that require us to recruit either the endurance or the fast twitch muscles. So if you're about to cough, you would contract the pelvic floor muscles, hold it, and then cough. And that would be for about a second to 3 seconds. For example, a sneeze, kind of the same thing, getting out of a car, lifting something heavy, right? All of those things last for short periods of time. So just practicing that quick contract, relax, contract, relax, contract, relax, and really focusing on the front of the penis and not on the back. So it's the cue that we give to men is nuts to guts, or stop the flow of urine, even better, try and lift the penis hands-free. So with your mind, use the muscles that move your penis. And I always recommend that men do this naked in front of a mirror so that they can see the movement of their penis. And that's the benefit of being a man, because you can actually visually see whether or not you're engaging those muscles. And the other one, as I mentioned, is really about holding that muscle contraction for a good 10 seconds, breathing normally, counting out loud, right? Not trying to hold your breath and make it more challenging than it has to be, because that doesn't reflect normal life. You should be able to maintain a normal conversation. And then slowly, slowly, slowly let go of the contraction, and then have equal rest time. And then you repeat that again. Hold for 10, rest for 10, hold for 10, rest for 10, and you repeat that 10 times. And this is high intensity, guys. So this means this needs to be done before and after breakfast, before and after lunch, before and after dinner. It needs to be done often so that these muscles get stronger. And it needs to be done at an intensity that's going to create fatigue. If you don't train these muscles to that point, you can't expect that you're going to get any results. You can't expect that I'm going to go and do a bicep curl twice, and then I'm going to go on with my day, and then I'm going to come back, and then I'm going to do another 2, go on with my day, and maybe just before bed do another 2, and I had a total of 6, but that is not going to create muscle growth. So you can't just do these exercises randomly as you're walking about, maybe stopping at a light, like many of my patients do. They say, yeah, well, I was doing it while I was sitting at the computer desk, or I was doing it while I was driving. No, you've got to do it, and it's got to be a committed exercise session, okay? You've got to really invest some time into getting these muscles stronger. So if I was to ask everyone now, everybody stand up, don't be shy, nobody sees you, just stand on up. And how many just had a leak? And so my question is to you, did you try and contract the muscles? Did you try and lift the penis, or nuts to guts? Did you try and hold that while you were getting up? So let's try that again. Sit back down, take a deep breath in. As you exhale, lift the penis, contract it, hold it. Don't be too hard. Too hard will actually cause more leakage. You just want to be gentle. And then try and stand up nice and slow and see if you can do it without sensing any leaking. So you've got to be mindful. Although there's this training protocol where you've got to do it 6 times per day, and it's got to be a committed effort of time, you can't forget to put it into play whenever you're not exercising, right? You've got to use these muscles during the activities that are causing leakage. And if you constantly notice that getting up from a chair is causing leakage, well, then that becomes your exercise protocol. Then you should do, 30 reps of that very movement and continue doing it until you get fatigued, until the muscles understand that they have to fire with that particular movement. I hope that makes sense. I hope that you guys learned something new in this webinar. These are just some reminders. Remember, technique matters. You're Hegeling, you're not Kegling, okay? Intensity matters, train to fatigue. The pelvic floor muscle training enhances strength and blood flow to the external sphincter, which can promote healing and recovery. You've got to try and perform these exercises 6 weeks before surgery if possible. And if you experience pain with any of these exercises, you may need to learn how to do that reverse Kegel that we talked about at the outset. So just bring that up with your physio. And these are just some exercise recommendations for pre and post prostatectomy. These slides will be made available to you at the end of the webinar. Thank you so much for your attention, and I will take any questions if you have any at this time.
Good job. Hello?